Thank you everyone for joining us tonight. Today's presenter is Wade Veneman, a respiratory therapist with 24 years of experience and the clinical educator for respiratory care at community medical centers. His focus is critical care, mechanical ventilation, and research, and today he'll be walking us through APRV and TCAV fundamentals. Welcome, Wade Veneman. Welcome everybody. Thanks for joining. It's 5:02 already. We got to get going because I did go over a little bit on Tuesday, and it's a big topic. So thank you for those that have joined early and on time. I appreciate you. Just as a disclosure, I'm actually home. I got sick the last couple of days, so if I sound a little nasal, I'm not myself. But we'll be able to get through this all right here. So we're going to talk about APRV tonight. And again, the balancing act between when do we know when to start dropping and stretching and letting the patient breathe. I don't have any disclosures. This is my job. So learning objectives, we're going to talk about justifying the importance of lung protective strategies. You know, we can't emphasize that more, that anytime, any talk you discuss mechanical ventilation, you know, the gold standard or evidence-based has shown that you need to protect the lung as much as you can from the forward traumas, determine the indications and select the initial settings for APRV. And then we're going to analyze the expiratory flow waveform. And again, this is where TCAV comes into play, because what TCAV is the fine tuning of the time low, how to set it correctly based off lung pathophysiology. Interpret APRV graphics. So again, this is something important that a lot of times I look at the bedside and I watch the screen and I watch the patient, and I want to see if they're synchronized. Are they triggering breaths? Are they not triggering breaths? What type of inhalation exhalation pattern they have. Are they pushing air out? And we'll show you some waveforms, what it looks like when we're over distending them. And again, then we'll talk about the weaning side of it. I was up in Modesto last month. Chris and I were up there talking at the state conference for CSRC. And one of the questions I asked, just to let you guys know, because I've spoken on this topic several times, I've been to many places and discussed it. And what I always find out is I asked a question. I said, number one, I said, does anybody, there's about 80 or 85 people there. And I asked them, I said, does anybody here start patients on APRV? And nobody raised their hand. I said, okay, how many of you use APRV or want to use APRV, but the doctors don't want to use it, or the doctors want to use it and you guys don't know how to use it? And the last question I asked them was, how many of you use it for rescue? And that's when a lot of the hands went up. So there's still, I guess, controversy about when to start APRV, and it still sounds like it's used as a rescue mode versus initial setting. So hopefully I can paint a picture tonight about why you can start it earlier and you can wean from it. You don't have to change back to another mode. So again, looking at lung mechanics and lung protective strategies, if you look at a basic typical pressure volume curve here, this upper inflection point, we're going to call that plateau pressure, right? Because most of us are familiar with plateau pressure and keeping it less than 30. And the reason why is, as you guys can see my cursor here, as the breath initiates here, here's where the lung begins to open. And as volume fills the lungs open, if it goes anywhere higher than this pressure line or upper inflection point or into this beaking, you guys are all taught that in school with beaking, then this is where you hit the too much area, okay? Either too much volume or too much pressure, and you're going to cause lung injury based off of these. And some of you for the annual competencies, you remember when I talked about, well, the lung doesn't just collapse right away on exhalation. So again, it follows this line here and then begins its descent here. So again, it finds that critical closing pressure and drops down here. Now, down here below this point here, if we allow it to collapse below this opening pressure point, then again, that's allowing that all the alveoli that we've inflated, now you're letting them collapse and you have this shear effect going back and forth. That's called atelectasis trauma. But we're good at that. We fix them with PEEP. We set PEEP up. And again, that's to prevent them from collapsing. So somewhere between these two red lines here, somewhere on this curve, I can't tell you exactly where, but somewhere is the best spot. That's the sweet spot, okay? And the sweet spot meaning that's where the best FRC is, the best compliance, the best gas exchange. Everything is in that spot. So this is what we're always trying to maintain. Again, in the competencies, when I was talking about how lungs, when we talked about lung recruitment and these patients, if they sit on the vent on day 1, day 2, day 3, day 4, if they're on the same setting, same position, air is going in and out 24/7 back and forth, they're going to collapse. Again, they're not going to stay in the sweet spot. And that's what the recruitment maneuver for is, get them back here. Well, we're going to use APRV in the same way, is to try to recruit that lung, and then not only recruit it, but we're going to try to keep it open. Now, here's another way to look at it is this green box represents good, healthy lungs here. And we all know that we all have to deliver a tidal volume for gas exchange. That's normal respiration. But all of that tidal volume does not participate in gas exchange. And what we call that is dead space, right? Your VDVT, or Paco minus Pico divided by Paco. Okay, so if you deliver a tidal volume of about 500, about 150 mLs of that volume does not participate in gas exchange, just goes in and comes right back out. But the remaining tidal volume mixes with FRC. And again, FRC is your end expiratory lung volume, or your reserve, right? You hear a lot of people talk about, it's called the reserve. And when you have a large, healthy FRC with a gas exchange reserve, this is this volume. This is a normal, healthy lung. However, most of our patients don't stay healthy. Some of them get sicker. So represented by the red box is a, let's say, more of an ARDS type of patient here, that compliance is down, gas exchange is down. And again, if you still try to deliver that same tidal volume to this smaller compartment with the lower FRC here, you're just going to have a lot more dead space. Okay, because if you're not reaching those airways for gas exchange, you're just going to these areas of dead space and creating this big shunt here against it. So now you only have a much smaller FRC. And this is when you guys, when I mentioned about like day 4 or 5, when uh, let's just say that the patient's being moved from left side to right side and they desat, or you suction them, they desat, or they move and they desat, whatever it is, this is what's happened here, is they went from this FRC, 5 days later, they're down to this FRC now. Okay. However, there's a way to fix this and get and restore FRC back, and that's by mean airway pressure. So let's focus on mean airway pressure for a minute, and the ways how we increase mean airway pressure. So if you're familiar with a volume mode here, right? We set a tidal volume of 500, rate of 12, got a PEEP of 5. We have a peak pressure of 29 and a mean of 10 on this patient here, okay? On the right screen, we've got pressure control of 24 over a PEEP of 10, so total pressure 34. And there's our peak pressure 35, and our mean is 15 on a PEEP of 10. So over here we have a PEEP of 5 and 10. So if I go from 5 to 10 a PEEP, you can see it only moves that, but look how much more it moves the PEEP pressure up. Okay, so what are the 3 ways in either mode that we want to increase mean airway pressure? Well, number one, everybody's familiar with is PEEP, right? So if we raise the PEEP, but again, I warn you and caution you that you're going to also raise peak pressure doing the same thing as you're going up. So you may have to balance by going down on pressure control if you need more PEEP but less driving pressure here, because again, we still want to remain lung protective as much as we want. Or if you're in the volume mode and you're going to pump PEEP, you're probably going to have to turn down the tidal volume in order to keep the peak pressure lower. Okay, which are the other 2 options? Either raising the pressure control is another way to get mean airway pressure, or raising the tidal volume. The third one is your I time. And again, I time is a kind of a combination with the rate, because you need to have a lower rate to have a longer I time. And this is when some of the old days, when they had something called inverse ratio pressure control, is they put them in PC and they would take the I time out to 2 seconds. The problem with that is patients cannot tolerate holding their breath for 2 seconds on inspiration when they want to exhale after 1 second. So most of them had to be either sedated and or paralyzed in order to be synchronized with those kind of settings. But if I were to tell you that there's another way of getting a higher mean airway pressure with a lower peak pressure, as you see on this vent screen, this is by an APRV, we have a P high of 26. The peak pressure is 29, because I'll tell you why that in a minute, why it goes up 3 there. But also look at the mean though, the difference. See, the ratio is much higher. You have a much higher mean airway pressure versus the peak pressure. So again, that's where the more of the lung protective and recruiting kind of comes from this mode and doing that. So again, it's labeled as an inverse ratio, pressure limited, time cycled. I remember that from school. I was like, do we have to memorize all those, right? But the primary goal is, again, you're maximizing or optimizing that mean airway pressure with minimizing peak pressure. Again, if you can go to a P high of 30, your plateau is 30, right? It's not going to be any higher than that. And again, the advantage is you're going to not only open the lung up, but you're going to keep it open. And spontaneous breathing, as I mentioned later here, plays a big role in recruiting the lung. Now, a lot of times for indications, a lot of people, like I see, you see the bottom one there, because again, a lot of people still use it for rescue. But you still want to think about, okay, we've tried conventional ventilation. Somebody just has refractory hypoxemia, or they're getting severe ARDS, and their oxygenation is out of control. Then this is a mode to try if you have no other tools in your toolbox to use. If you just had, let's say, you had proning and a ventilator with APRV and conventional ventilation on it, this is what would be recommended to use. Again, high oxygen needs. So anybody that's greater than 50% or PEEP of 15 and you can't wean them, it's a good mode to try to use to recruit or try to fix whatever the problem is there. Diffuse atelectasis, those are kind of like the ones we talked about, like post-op patients or patients laying in bed in the same position for long periods of time uh, that develop that posterior dependent regions with atelectasis, and that they need this aggressive style. They've gotten so far now to where they've become refractory hypoxemic due to how much of their FRC they've lost, and again, the rescue mode. So if we talk about initial setup, again, this was one of the first articles written by Dr. Harbashi in 2005, other approaches to open lung. And this was one of the first ones when he kind of described the settings, what he was using. So again, back then he was talking about starting with a PI of somewhere between 20 and 30. That would be the recruitment pressure, right? That's what you're using to recruit. And then the time high is how long you're holding that recruitment. So again, it's open the lung and keep it open. So 4 to 6 seconds is what he found to be a good starting point. The P low at 0, again, that's the release pressure. You want to release as quick as possible with no expiratory resistance. And the time low, now that's what they've studied most of the time. And again, that's where TCAV, what I'll explain in a minute, that's where TCAV has come now. But again, before he used to recommend 0.4 to 0.8. But you can see now he has a new range of 0.2, and just because of the TCAV data that they have that. Now, if you're not sure where to start P high from conventional, then another one, and I forgot to list out on here, but as you measure a plateau pressure, measure the plateau pressure. Let's say it comes out 26, then start your P high at the plateau pressure 26. So then you know you're not going any higher than that number there. Now, the funny part is the ventilators and the manufacturers like to call these settings, right? If we all know them as P high, P low, and time high and time low, they like to call them their own different acronyms on the ventilators than we're used to. So if you look at the Servo U, for example, it does have P high and time high, but their P low, they call it actual PEEP, and then the time low or T low, they actually call it T-PEEP. If we look at the 980, it's a little bit trickier. Okay, so for those of you at Clovis that are on, hang on here with me for a minute and see if I can get this down right so you guys can get an idea of what I'm trying to explain here. But when you're looking at this window, this time, this is a IDE ratio or total respiratory cycle time, whatever. I don't know what they exactly call it, but it's more like a total cycle time here. You have three options down here in this window. Okay, you have your long bar here, the green bar 3.20. That would be considered your time high, and that's associated with this first lock. The middle one is your IDE ratio associated with the middle lock, and then your time low is going to be the far one. And you notice this one is locked here. So when you're setting up bi-level on the 980, what I recommend is you always want to lock the time low in. Once you've dialed it in where you want it at, you want to lock this function. So every other change you make, whether it's with the pressure, with the frequency, because your frequency now, this control here is what's going to control your time high. Okay, so you should know that if you're going to decrease your frequency, your time high is going to increase. Right? It's going to go out farther, so you're going to create less releases. If you increase frequency, let's say you go from 15 to 20, your time high is going to shorten up to probably close to 2.5, 2.2, somewhere around there, whatever. But make sure you lock. You don't want your T low adjusting, or don't lock the IDE ratio. That doesn't mean anything because your patients are going to be initially spontaneously breathing, so you don't need a fixed IDE. But the main one you should only be moving is the time high on this. And again, when we talk about weaning, that's all the two parameters you need to worry about. Once you set P low to 0 and once you set your time low, when you dial it in, these two you don't touch anymore. You just touch these two to wean. So P high comes down, frequency would actually go down to increase your time high. Now, I just wanted to share with you what some of the other ventilators do, because this one here on the right is the Hamilton. So again, they call it APRV, and they call the controls all the same: P high, P low, time low, and you can't see time high on there, but it's P high. Now the Draeger was the first vent that actually had the licensing for APRV to put it on there, and their newest software actually have added this control right here, and this is expiratory termination. And what this is instead of setting time low at the peak expiratory flow percent where you want it to stop, where I'll show you later how we have to calculate it. You just tell this on the ventilator, you just tell you want every single breath right here. So every single breath, you want it to terminate at 75% of that peak flow. So whether it's a spontaneous breath or a controlled breath, every breath will terminate at 75% of expiratory flow. So to me, that's, as a clinician, that's a lot easier to set up than you'll see the steps that we have to go back to calculate it. Your time high should be, if it's 4 to 6 seconds, that should roughly be about 90% of your inspiratory time or total cycle time. And you've heard some people call this upside down pressure control or inverse pressure control. What they mean by that is if you flip this waveform from here's all inspiratory and here's expiratory, if you flip it upside down, this would be your inspiratory time and this would be your exhalation, right? So it just has a longer, say if this was a 4 to 1, you flip it around, you have a 1 to 4 ratio. So again, another way that they look at it to explain it. Now the P low at the bottom, from these studies, what they found is that there's certain uh, expiratory valves in certain ventilators that hold a lot of expiratory resistance within them. And when you're trying to empty CO2 on the release as much as possible, so I've got a slide coming up on that, you don't want any expiratory resistance. You don't want anything slowing that flow coming out of the lung, right? You want to empty the CO2 as quick as possible and then reinflate the lung before it gets below critical closing pressure and it collapses. So what they found is that zero added no, because what is PEEP? PEEP is positive and expiratory pressure. So if you're trying to dump from P high down to P low and you add PEEP on the bottom, you're going to slow down that release time. But by going to zero, you have no resistance at all. You're going to dump quickly and then reinflate as fast as they can. So again, that wasn't just a number they just came up with. That was actually what they studied and found that they had better CO2 clearance that way. Now, TCAV is, again, this is the method what they've come up to now and um, what they're publishing about. And this is, again, this is how they're fine tuning the time low. And I'll show you some graphs here what the angle looks like in a minute for some of these different expiratory flow frame. But again, the goal is to terminate the expiratory flow before the alveoli completely collapse. And there is another study out there. I always forget to put that one in this one, but I should, one of these times I will. But they show what the actual lungs look at. They've got this microscope up in New York with Gary Neiman, and you look at the actual alveoli inflating and collapsing. And what they did is they studied at 25%, 50%, and 75%. And they watched the alveoli at 70 and at 25%, there's a lot of them that collapse. 50%, about half of them collapse, and 75% is where the majority of them actually stayed open. Because again, alveoli should not move very much. They should just barely move in and out. Okay. They barely move with tidal ventilation. And so when you're studying this kind of stuff, that's what you're looking at. You don't want them collapsing, re-expanding, and things like that. That's that shearing trauma they cause. And they have really good pictures in that article that show you each of those terminations when they're doing it. So again, the rule now is, and again, the gold standard, what they're trying to aim for is 75% of expiratory flow. And again, why is because this maintains functional residual capacity and minimizes that shear stress of villi. So if you look at these angles here, this is a normal lung, and they've got the time low set at 0.5. Okay, so peak expiratory flow set at 0.5. And notice a normal expiratory flow waveform should be about 45 degrees. And again, that's why they're showing this little compass here. Should be about 45 degrees back to baseline. Okay, even though you're shortening it, it should be this angle. Now, as the lung gets stiffer and starts migrating into ARDS, so let's say they go from stage 1 and now they're going to stage 2, the lung's going to get stiffer. By shortening up the time low is what you're going to need to redo that angle, because this angle is going to change. If it was still at 0.5, it's going to change and get flatter, and you want that to empty here quicker. So you're shortening the time low. And it's also based off of time constants. I think I have a slide on here on that about how fast the lung is emptying, because the stiffer the lung gets, the faster it's going to empty. So you can shorten these time lows on these severe ARDS patients. And again, you can see the slope, how much steeper it's getting here and changing with severe ARDS at a much lower time low. So with easy math, again, the easy calculation is if you have a peak expiratory flow rate, and again, how you measure that, I'll show you on the vents here in a minute. Let's say it's 100, and then you times it by that 75%. So somewhere around 0.75 is where your termination should be. So if you look at, here's a servo, and the time low is set at 0.7. Okay, so what you need to do is you need to go in the top right, and you need to, that's what this little camera is. You hit the little camera, sorry, well, it's the recording part, not the camera snapshot. You got to do a video of the screen. And when you press that video, it does 15 seconds before and 15 seconds after when you press it. And that's what this line right here is mean. Then you hit the little file in the corner. And when you go back, I had a screenshot of it here. Did I go too big? No, I didn't. Anyways, put the cursor right here on this point right here. Okay. And you're looking for the largest negative number right on the point. That's your peak expiratory flow rate. And here in the yellow box, it's negative 77. Now what we're going to do is migrate the cursor up to here at the termination, and see I've noticed it's put it right here, and they should all be like 1, 1, 1, maybe 2, maybe 1. They should be very close together until you see this significant change from negative to positive, and that's when inspiration starts. So make sure you're getting a negative number and backing off to right where it terminates here. And the number we're getting here is 25. Okay, so you would take 77, that was our initial peak flow rate, divide it by 25 is where it's terminating, and we get 0.33, or if you times that by 100, it'd be 33%. So if our goal is 75% and we're only at 33%, what changes should we make to time low? Anybody want to take a guess? I don't hear anybody. So the answer is you would shorten time low, right? So we're going to shorten time low down to trap more and get closer to a 75% number. This just means that we're opening too much here. We need to tighten this up a little bit here. Now, if you see a waveform like this, it's just spiking like a real sharp spike and then coming up and then emptying here. Do not count this lower end here as your peak expiratory flow rate. That's usually caused by one of these factors here. Like if you had an adult with a really small tube, so there's a lot of airway resistance. You have filters in line or something that's causing artificial airway obstruction. There could be plugs in the airways, expiratory or too much PEEP, secretions. Any of these things here could be causing this waveform. And actually, when I was at Clovis, I was able to capture this screenshot. And here's one that's happening right now. What was happening is you see this big spike down here. But again, this is what you want to call your peak flow. You want to start it about right here. So if you were to zoom in on that, you'd stop your cursor right at that end there. So see, we're at 39.4, and then you move it up to here to 27.6. You calculate those two, and we're at 70%. And that's right where we should be on termination of peak expiratory flow. Now, if you're having trouble with CO2 and the time low, sometimes if you do shorten it too much, again, you're not emptying enough CO2. So you always want to make sure, one, to optimize your time low. If it's too shut, and again, flow cut is above 75%, that's why you want to check it, make sure you're not at 80 or 90%. You won't let a lot of air out. That mostly is member CO2. So then you would just stretch out that time low. Say if you're at 0.3 or 0.4, maybe bump it out to a half or 1 to get more volume. And you'll see your volume increase as it comes out. If your CO2 is too low, then again, your time low may be too long. So you're way up here, maybe at 25% expiratory time. So again, go back and recalculate it. And maybe you're not at 75%. You have enough room then to shorten your time low. Now for, excuse me, if you're looking at oxygenation, remember oxygenation equals mean airway pressure. So again, have you optimized, if you're having hypoxemia still, you haven't optimized your P high, then again, that's your recruiting pressure. So you're going to always optimize or raise P high first to make sure you're raising the mean. Second, then you're going to hold it in there longer. So again, you're not going to shorten it. You want to lengthen it out so there's more time at high pressure. And then emphasize again, if you're less than 60%, you need to turn up the FiO2, that's fine. But I think most of us that use this mode see that a lot of times it's usually once it starts working within that 4, 6, 8 hour range, we're mostly already weaning FiO2 down pretty quickly. And it's usually not FiO2 that we got to go back up on or change once we've opened up that lung. Please remember that APRV without spontaneously breathing is not a mode designed to ventilate patients. So if you're having high CO2 issues and your patient is not spontaneously breathing, this is why a lot of people, you'll see them shorten the time high down and things like that, is because they're going to try to now ventilate the patient. So one factor is, again, the patient is the variable. That's the one that actually, will increase the minute ventilation and going on that. And I think I have some slides on about how to look at their spontaneous minute ventilation. But first we need to remember what position they're on. So if you look at the way that they're being ventilated, it's really laying flat on the bed here. And you got your ventilator here and it's pushing air into their lungs. Again, based off of gravity, most of it's going to go upward into the non-dependent or up in the upper chest area. And down here in the posterior dependent regions, that back here in the posterior, the lower lobes behind the diaphragm here are the more susceptible areas or high risk areas. And this is a CT here. This is, again, you can see all these air bronchograms so that you know it's not consolidation, but it's atelectasis because you can see the airways are opening through here. Then you know it's a bunch of atelectasis. This is kind of like the magic or the key behind APRV with spontaneous breathing because if you just inflate air into the lungs and the diaphragm's not naturally moving, then you're just going to get air in and air out back and forth, right? What I talk about. But once this diaphragm starts contracting downward, that's actually what they show looking here in this area, what gets distributed down in these bottom areas here. So if you look at this waveform here, this is showing that the more sedation or paralytics you on board, see how much the diaphragm is shrinking upward. So you're losing FRC. You're already losing it because you're flat laying down. And then when you sedate somebody, the diaphragm contracts upward and you lose loss of volume in your lungs. And then when they paralyze, you lose even more. So again, all that area is going to automatically collapse just by doing that. So a lot of the keys is that spontaneous breathing. Now, this was an abstract poster presentation that we did back in 2015 at the AARC in Tampa. And what we were looking at was, this is when we're using it downtown for trauma patients. And, one of the biggest questions I keep saying is, if you recruit the lung, you increase FRC, but how do you prove that? How do you actually show or demonstrate that we actually do increase FRC? So the old days with our old GE ventilators, for those guys that have been around, we were able to measure FRC at the bedside. And this, I know it's hard to see on the screen, but this is a snapshot of what it looked like when it did a modified nitrogen wash in and wash out. But what that was able to tell us is when we switch patients from conventional ventilation, so we know their FRC was de-recruiting or collapsing, right? And we've got to recruit them now. Does their FRC actually increase? And if it does, how much does it increase based off of their predicted body weight through the PFT lab, which is the ATS guidelines? So if you look at this graph up closer here, their average or mean FRC was 1.8 liters. Remember, a lot of people should be around 2.5 to 3 liters, okay? So you can see it was decreased to about 1.8 in conventional ventilation. Once we switched over to APRV, we remeasured, remember the literature for APRV says wait to about 6 to 8 hours to get your first gas. So we waited to 6 to 8 hours to get our first FRC after we switched. And when we did that, you can see that we had a 20% increase in FRC from those patients' predicted body. So they went from a mean of 1.8 to 2.3 liters. And again, that's a 93% 93% compatible with their predicted. So as we predicted them, we almost restored their FRC by 100%. So we got them at 93%, which obviously their gas exchange improved. So if you look at their PF ratios from 240 to 272, the means, there's the big difference, remember. So you're almost doubling the mean airway pressure. However, compliance got better. Tidal volume stayed the same, so we weren't over distending or causing any more harm. Plateaus were about 6 above. Now, one thing that we calculated in our data after the presentation, because this came out after this lung strain, is there's something called lung stress and strain. And Gatnoni wrote about this in his paper calling it the baby lung. And if you guys remember that any patient with ARDS, all the different zones in the lungs are all affected by one thing or another. For example, some are collapsed, some are fluid filled, some are over distended, some are bronchospastic, some are normal. There's all kinds of, right? It's a heterogeneous disease. There's multiple things, but somewhere in all that disruption of the alveoli is there's a normal area of the lungs that are working, and that's what he's describing as what he called the baby lung. And what they looked at is trying to reduce, again, lung protective, trying to reduce the 4 traumas: barotrauma, volume trauma, electrauma, and biotrauma. They're trying to reduce those from VILI, that's ventilator-induced lung injury. They're trying to reduce that, and they looked at the stress and strain. Now, lung stress is the amount of pressure, that's the barrel side. Lung strain is the volume side. And when you take lung strain, the calculation there you can see in the bottom is it's just take their tidal volume divided by their FRC. If you look at the bottom graph on the green, the row there, in the conventional ventilation, theirs was about 35% strain. And when we went to APRV and opened up their lung strain actually decreased, again, stating that their lungs were more compliant and it was being ventilated at a safer volume of gas once we opened it up. So that was something that we were kind of shocked about after we reduced that. Again, that's just for you guys, what that really means is just that APRV is a lung protective strategy. Again, another way to look at it, simplified. Now, this is Dr. Amato, Marcelo Amato. He's out of Sao Paulo, Brazil. And if you guys have heard the term driving pressure, right? You've heard the doctors talk about driving pressure. You've talked about them targeting driving pressure. He is the person who wrote the original article in 2015. Again, this was the same year, like I said, when we did our presentation in 2015. And this is when he wrote about how I use the pressure. And again, your driving pressure is your plateau minus your PEEP. So if you have a plateau of 30 and your PEEP's at 15, you're at 15. And again, he says anything less than 15 is being lung protective. Now, one of the highlights in my career, and hopefully my friend Angel, I don't know if he's on or not, whatever, but him and I got to go down to a conference at Loma Linda and actually meet Dr. Amato in person. After the conference, we actually got to go to the pig lab and we did recruitment maneuvers with Dr. Amato. And I remember when we had to rotate stations, we went to the other lab where there was another pig on a vent, and we were supposed to do. Sorry, I got to think for a minute. What's the other PAV? We were supposed to do proportional assist PAV training on the pig, but Angel and I were trying to talk the guy into letting us use bilevel, but he wouldn't let us do it. So we wanted to set up APRV on the pig to see how they'd respond to it. But the reason why I'm showing you guys this is because um, there's a lot of naysayers about APRV that say that it is not a lung protective mode because of the driving pressure. And if you think about it, if you look at plateau minus PEEP, that's what they're saying. Okay, right? So if you have this person here, this vent right here, the screenshot you're looking at right now is 30 over 0 right now. Okay. So in their eyes, they're saying, okay, the P high is the plateau pressure. So if you have, that'd be P high minus P low. So if you have 30 minus 0, right, because I have 30 over 0, then the driving pressure would be 30, and that's double what should be normal for a lung protective vent. Remember, it needs to be below 15, and that's not true because we actually purposely trap end expiratory pressure and lung volume inside the lung. So this is not true. So don't think this. And this is what they were trying to show. One of the conferences I was at Las Vegas, I actually had to walk out because I couldn't believe that they were um, compelling this argument to the audience saying that don't use this mode because it's unsafe. And I'm like, that's not true. Now let me show you why it's not true. So it's actually P high minus total PEEP, right? There's two components of PEEP, intrinsic and extrinsic. Just because we have 0 set on the outside, we also have a component called time low that's trapping an expiratory pressure. So here on the screen, you're seeing I did a recording. Right here's the recording button. And right here is an expiratory hold. You can see there's no flow going through the lung. It's a static hold, no flow. And right here, I put the cursor. I probably could have put it a little bit more over here, but if you look at the number, it's 18. This is actually my PEEP, or this is my intrinsic PEEP that we're trapping inside the lung. So if you recalculated that, 30 up in P high minus total PEEP, our driving pressure is actually 12. So from 18 to 30, right here on this increase, not from 0 all the way up to 30, it's not our driving pressure. So again, if you're ever asked to calculate that or if they're arguing with this is not true. We actually are being still lung protective and monitoring that. If you're using the 980, do the same thing, do an expiratory hold. Your total PEEP was 19. Again, your peak pressure was, your P high was 30. So again, 30 minus, oops, hit too fast. 30 minus 19, you're at 11. So again, you're less than 15, so you're in that safe zone there. Now let's take a look at some waveforms, just some things that I point out here. This is right here on the title. If you look at, I'm at 32 over 0, 1.8.6. This is kind of like what I'd look at as a TCAV thing. This is where you're really shorten TCAV and this is where you're taking the patient out of the picture, the equation, because they're probably getting more septic and ARDS style, and you're shortening that time. You see this time low is getting a lot shorter. It's at 0.6, but you got to go shorter than that to get this down more. But you're going to control more of the ventilation now than a standard APRV where you stretch it out. Now, I remember this was a patient that I was walking through the ICU. And one of the first things, again, when I look at these waveforms and I look at the patient, is what I noticed is the patient, if you guys see my cursor, follow me here, I'm on the green on the flow here. Um, I can see the patient's exhaling continuously all the way through the cycle. And the reason all the way down through here, because look at the volume. See, the volume was at peak here. So they took a breath at the end and they're pushing the volume all the way out, all the way here through this as it cycles up into P high, and they're pushing. So again, they push all that volume up, and here's the volume filling when P high goes up. And again, they're trying to exhale down, but then they take another one on top. Okay. And they took one giant breath here. Let's see, one of the sulca time, and this is set at 6 seconds. And you think, wow, 6 seconds is really long, but technically it's not. If you have a 1 to 3 normal IDE ratio, and you go 1 to 3 and 1 to 3, that's at 6. You can't even get 2 breaths in that. That's another way to think about it. So I made the recommendation. I said, just stretch out the time high from 0.6, or sorry, 6 out to 8 seconds. Don't make any other changes, just take it. And then wait a few minutes. And when you wait a few minutes now, this is the same exact patient. You see now we went from 6 to 8, but notice how the volume is consistent and the rate is consistent. See how they're emptying to the baseline, 45 degrees? And look at the volume consistent in the lung. This is maintaining that FRC standard. Okay, this is what it would look like, what you're looking for on a patient. Again, you have that empty. Notice it never gets to zero, right? Because of the time low, never gets to zero. And then when it inflates here, you can see that patient taking nice, normal, spontaneous breaths. And that's the key to look at, because again, now you're believe it or not, your minute ventilation is going to go up, but also you'll see tidal volume go up. And everyone always asks that. It's like, I went out on numbers and down on pressures, and why did my tidal volumes go up? And again, you're allowing that patient now to breathe on top of FRC. If you're over distending, you're not going to be able to see that. So you have to watch that and make sure that that lung is staying compliant there. Again, this is another just a zoomed in version of somebody who's not spontaneously breathing, but I can see they are. If when you have this big long stretch here, and then they empty, see how it's more flatter here because they're pushing, and then when the P high inflates, you see the dip there, and it goes out, and then it goes negative. That person's exhaling right there. Okay, and you see the volume is up. So this is either they're not awake, and also another key is look at the tidal volume. Nobody should be exhaling 900 tidal volume in 0.5 or 0.6 time. That just means their overall lung volume is enormous. It's a lot more than what it should be. Now here's a video of watching it too. And again, look at those volumes are 900 and 800. So again, keep an eye on those. I had another one. There's another one that's interesting that here's a 980 that looks if you look at this one here, this is what the 980 would look like. So again, looks like somebody's on about 20, 26. See the frequency, see how the frequencies turn down because the P low, I'm sorry, the time low, you can't see that little window, but that little window of the time low is locked. So the time low is going to be the same at every breath, and you lower the frequency to stretch the time high out. And look how perfect as it inflates P high here, there's a nice spontaneous breath, empties, and see how that volume is staying consistent in the lung, emptying it, releasing it, again, CO2, right? Emptying CO2. And so that's the smooth way what it should be. I was trying to do a pop quiz on here, but if I don't know if I can get anyone to speak up again, but if you don't want to, what we were doing, first of all, see this pulse ox pleth? I hear a lot of people say this, and I want to make sure everybody understands this, that can anyone tell me what sensor this pleth is coming from? Anybody want to guess what sensor? I'll give you 3 choices: finger, ear, or forehead.
I'm gonna guess forehead.
Okay,
Finger.
something I heard finger. What else? Yeah, don't say ear. Nobody say ear, please.
Ear.
Is my camera on? Can you guys see me crying? I know someone did that on purpose. So the answer is finger. And again, I had a screenshot of the forehead above here on the other one, but I took it off for time. But if you look at here, this looks just an art line, and you look at the CVP line. But if you watch an art line, see this dichrotic notch right here? This is an accurate reading of pulse ox because of that finger digit. You do not get this with the forehead sensor. The forehead just kind of looks like a tidal volume going up and down. Kind of looks like a long, slow VTAC or something. So again, you guys should be able to recognize those and be able to tell what sensor, but also look at the CO2 down here. So again, if you're an APRV, you've got this really short release, short release, short release. I mean, yes, I recommend CO2 as a trending tool. So even in APRV, you can use it. But look at the one at the end here. What do you think we did? Why did we get a longer capnogram down here at the end? We did a hold. So we actually did an expiratory hold where we were measuring that screenshot where I was measuring the intrinsic PEEP to see what kind of PEEP we were trapping. And look at there, I got a full capnogram. So again, just other things I want to share with you guys. If you're curious about, again, the end title is only going to spike right here at the end title, right? The number is just going to spit out whatever the end title is. But if you had a lower airway obstruction, then this would look more like a shark fin coming out, right? So if you held that, but here you wouldn't be able to tell if there was a shark fin. But if you did an expiratory hold just to observe the capnogram coming out of there, you'd be able to look at that and go, oh, okay, I've got some lower airway issues there. So little things to do at the bedside. So again, let's talk about drop and stretch. Am I doing on time? Okay. So this has been a coined term again from what Dr. Abbasi originally um, published the paper in 2005 about this mode. And again, what we're trying to do is gradually, if you have the patient on the vent, that's the control side. All I want to do is reduce some of that control and pass it on to the patient. And I want the patient to start picking up. As I reduce the control of the vent side, I want the patient to start picking the other side up. So you want that balance going on there. That's why it's important to see like what total minute ventilation is doing, and then what part or percent the patient's actually breathing on that total there. So again, the core mechanism, you're reducing mean airway pressure. But as you go down on P high, that's why you stretch time high out. So you're keeping mean in there to keep that lung recruited. There is the mistake is sometimes that people will use APRV to rescue a patient, and they'll recruit them and they make everything perfect. And then they'll want to switch back over to conventional. And again, for years, I'd always say that if you're not going to extubate that patient in the next 24 hours, I wouldn't recommend doing that because they will de-recruit. Again, you're going to go back to that. Remember that picture, the person just laying there flat, air in and air out? That is not enough pressure or mean to hold or keep or retain that FRC. And this method is the only way you'll be able to do it all the way down to CPAP. Because remember, that's all we're using is just straight CPAP here. So again, the effort should be monitored. So this is what it'd be looking like if you're going from controlled. This would be like hardly any spontaneous effort. And then once you start dropping and stretching, you start getting the patient to start taking some breaths. So it starts weaning these, Habashi calls them CPAP blocks. And then eventually you want them here just breathing one big SBT, right? With just one big long CPAP level. Now, there's nothing been published. And again, based off my experience, it's hard to tell you guys how much to wean it by because every patient's different. And what you need to do is just monitor them and see how they respond to it. So always start with the P high, dropping it by 1 to 2. And I usually stretch out the time high. If it's at 6, I'll go out, 1 to 2 seconds. But you want to start watching the patient because if you're right at their normal FRC and you go down too quickly and you de-recruit or they get too much of a low FRC, they're going to try to. I'll show waveforms of what they do. Their brain, your signals, your receptors in your lungs will tell you if your lung volume gets too low, it tells your brain to take in deeper breaths, right? And you'll see this on the ventilator, how they do this. I've got some screenshots of it. And all of a sudden you see this big increased work of breathing because they're trying to get their FRC back up. So again, just turn that P high back up from where you turned it down and let them get back there. And again, the effect is you're trying to decrease that driving pressure for the releases, reducing mechanical support. You're getting more spontaneous effort. And that's what we're trying to look at here. Again, take the time high out and you're going to stretch that out. Some patients, like that patient that I showed you the video that was the one that was releasing 900 tidal volume, I show you guys the video. That's actually a good example of what, when I looked at that and saw that, I'd go, why aren't we weaning this patient, right? Because if somebody's opened up and recruited and and this is the way you got to think about it. If they're exhaling 900 tidal volume in half a second, what's their overall lung volume, right? So we're probably at a point where we're almost over distending them. So that tells me there that they should have been weaned already. They should have been dropped and stretched out and ready to go instead of just breathing in. They're still kind of in that control side. And you got to get them down to that interactive side. So this one here, remember I showed you when we stretch them out from 6 to 8 seconds and notice the whole pattern immediately change once you allow that patient more time at the PI to take those breaths. So this was a slide I talked about. Can we monitor spontaneous effort? And the answer is yes. Right here on the servo on the windows on the right side, if you open up the window, right here, this inspiratory, this would be the total minute ventilation right here. And then exhaled spontaneous. So you can see that the patient's doing 6.6 of the 10.4 total liters right there. And on the 980, yes, you can also change these up here. So you have your exhale tidal volume, your PBW, that's your spontaneous tidal volume. But also see here's your total minute ventilation and there's your spontaneous minute ventilation. Okay. So again, based off these smaller tidal volumes, they're doing about 50% of the work. And that's what you want to monitor and keep an eye on those things. So again, where you're supposed to end at, there's different protocols out there, but if you get somebody down a PHI about somewhere between, I've heard numbers like we go to 15 and 15, we go to 12 and 12, we go to 10 to 10, whichever you think is there. Again, it's your assessment of looking at them and watching their mechanics and their breathing. And you'll notice because once they're recruited and their compliance is good, then it's not taking much volume. They're breathing barely any 10, 12, 15 a CPAP. It's nothing at all for them. And all the ventilators, depending on which ones you use, depends on how high the time high goes out. Some go out to 10, 15, some go to 20, some go to 30 seconds. Um, Now, here's where I want to caution you is because they're almost pretty much doing an SBT, but if you want to do one as an official SBT, please don't do pressure support over CPAP 5/5. And again, if anything, I want you to take home from this talk is about the mean airway pressure. If you have CPAP of 12 to 15, your mean airway pressure is two less than that number, okay? But if you take them all the way down to a 5/5, you're dropping again their mean significantly. You're going to most likely cause atelectasis during their SBT, okay? So the best way to do an SBT that's still following protocol is if you take 5/5, the total pressure is 10, right? Well, we can also use just a CPAP level. We don't have to use pressure support. So you would do CPAP at 10 to start somebody. So if I got them down to 15/15 or 12/12, switch them over just to CPAP at 10, that would be my SBT. And again, you would assess them something like this. So here's one that we switched over. I haven't done any recent. I know this is an old picture, but this kind of hits home with the message. I mean, is this patient sees no pressure support just on a PEEP of 10 here, but look at their mechanics. I mean, they're taking nice big giant breaths on 10 of CPAP because that lung is recruited and still open. And look, the peak pressure is 12 and the mean is 10. Okay, on a CPAP of 10. Now remember the 12, you're getting the 2 because all these ventilators have 2 to 3 centimeters built into them because of airway resistance of the tube, ET tube. So you see here when it increases upward, you get that 2 to 3 centimeter. All the ventilators do it. The servos, the 980s, all of them have that on there. That's why when your peak P high is 26 and your total pressure is 28, 29, that's where that's coming from the machine. That's why you don't need to use any pressure support because it's already built into the devices. But look at this guy's exhale tidal volume. He was doing 876 on a CPAP of 10. So we weaned him to 8 in about 5 minutes. Tidal volume stayed like 600. We weaned him to 5 of CPAP, and about 20 minutes later, we extubated, and he did great. So again, think about this is a better way to do an SBT if you're coming out of bi-level than switching over to 5/5. So with all that, thank you for hanging in there and sticking with me. And again, as my summary is, it is a powerful lung protective strategy mode. Hopefully tonight I was able to demonstrate you that it is lung protective, it is safe. Again, it's all in the hands of the clinician who's setting it up. So that's the purpose of these classes. If you're not sure, always ask if you get an order, set one up. We've got plenty of experienced staff on both facilities that have used these modes. Again, managed by the guided TCAV. So just remember the 75% rule. I've always still taught 50 to 75%. I feel that we've done pretty good, successful there. But again, based off the study that they've been doing with TCAVs, they're saying that 75 is still optimizing the best FRC and decreasing Billy. And again, when you're doing the weaning, try to remember the SBT. Don't do 5/5. Try to go to a CPAP of 10, start them there, and then wean them down. Most likely, they'll do 5 and a CPAP of 5, but you can start them at 10 and work them way down. And that's all I have. Again, I think RT Week for 2026, I've always wanted to make this t-shirt. The front's going to say APRV, drop and stretch, and the back's going to say let the patient breathe. Thanks, you guys. Thanks for joining me tonight. Hopefully I sound okay. I'm a little stuffy. still at home, sick and stuffy. There's all my references. You guys want to review them, but anybody have any questions? How do I get to the chat here?